Coordinator with Metro Atlanta Trauma Advisory Committee. Welcome to the MTAC Monthly Trauma Conference. We hold this conference on the third Tuesday of every month on varying topics related to trauma, so we hope you join us again in the future. Our topic today is the transfer and transport considerations for the trauma patient. We're fortunate to have Dr. Joshua Loyd with us. Dr. Loyd trained in emergency medicine at Virginia Commonwealth University and completed an EMS fellowship at Carolinas Medical Center. He currently serves as an emergency medicine physician with Mid-Atlantic Emergency Medical Associates and is the medical director for Novant Health Critical Care Transport and Novant Health MedFlight. With that, thank you, Dr. Loyd, and I'll turn it over to you.
Thanks, Scott. I appreciate that. Good afternoon, everybody. Thank you for inviting me. Very happy to help with this process. I've been an active member of MTAC for several years now on the EMS subcommittee, and I hope to give you a little bit information about transport and transfer of the trauma patient. I don't really have any financial disclosures. I will disclose, obviously, I work with Novant Health and MedTrans GMR, so we will be talking about trauma centers and HEMS programs, so just know that that's kind of where my allegiance lie. If you want to give me money to buy a cool response vehicle like this, I'm certainly happy to put you on my disclosure list. Got a lot to talk about today. When we originally kind of discussed what we were going to cover today, we were looking at just interfacility transfers, as that's my current role. But given my EMS background, I was asked to broaden the scope of today's talk, which I'm happy to do. The only limitation is when you cover all aspects of pre-hospital treatment, all the way through transfer of the patient to a tertiary care center. That's probably a year's worth of education, and I'm going to try to do it in 45 minutes. So my goal today is to hit the highlights of what I've learned since I've been a credentialed EMS provider for actually 20 years this year. Give you some key takeaways, some key learning points, and then, of course, always happy to open things up for discussion. I will note if you ask me any hard questions, I see Doug Swanson's on, since Dr. Swanson was the fellowship director when I trained at CMC. We'll ask him all the really hard questions. All right, first, so I want to try to go in order of when we get to a trauma patient from a pre-hospital perspective, sort of what treatments, decisions we have to make, and kind of where those decisions lead. And so my first slide, I want to just talk about what's actually important in the treatment of trauma patients by EMS providers. And I like the ABCs. I know sometimes we put it CAB instead, but at least I learned it at ABC, so I like to at least talk about them. And again, there's only a few interventions that we have in the back of the ambulance that really do change outcomes for our trauma patients, and they really evolve around airway, breathing, and circulation. I think we could argue whether blood and TXA in our current region really saves lives, yes or no, in the pre-hospital setting. But we do have certain things like the ability to position people's airway, needle thoracostomy, tourniquets on our ambulances that absolutely can and have saved lives for our trauma patients. I think a lot of people forget about the S and ABCs, and I always like to reiterate scene safety is incredibly important. EMS providers lose their lives every year across the country by being involved in motor vehicle collisions. So you got to get to the scene safely, and you've got to protect yourself on scene to save lives as well. The general kind of consensus is EMS providers have 10 minutes on scene to get whatever they need to get done and then get off. A lot of places like Mecklenburg EMS, where I trained, specifically have a goal around 10-minute scene time. I would argue that unless you're doing one of the ABCs, 10 minutes is probably too long, and some of the calls that I ran, incredible care given within 4 to 5 minutes, patient leaving the scene and taking care of everything it doesn't need to be taken care of on scene while you're out to the hospital. So speaking of what matters beyond treatment, there are a lot of critical pieces of information that EMS providers can get while they're on the scene that's incredibly helpful to the receiving center. And I list them out here, but basically the initial set of vital signs, what happened to the patient, highest heart rate, lowest blood pressure, and GCS, at least an initial GCS, can be incredibly important and really can't be replaced by anyone else. There's a lot of treatment we can do at the receiving hospital, whether it's a trauma center or not, but those are pieces of information that we can't get from anybody else except for EMS providers. And so if you can at all possible get that and get that to us early, super helpful. Things that we love to see when patients arrive to the hospital, IVs and pain management and cardiac monitors, all the other stuff is really, really nice. And if you have the time, please accomplish all these things as necessary. But I would not spend a single second on scene attempting to get any of these done, nor would I delay the efficient transfer of that patient waiting for those. Next thing you got to do is got to figure out where I'm going to take the patient. I think this is a great area of interest for EMS providers in some of our outlying communities. Here in Charlotte, it's pretty easy. We have multiple trauma centers, and the trauma centers really aren't that far from the location of any trauma, say in Mecklenburg County. But if you're in Rowan County, it may be a different story. So we always, a lot of times, have a community emergency department that is closer than a trauma center, and it can be tempting to go to a community emergency department instead of the trauma center because they're closer. Our emergency departments, community emergency departments, do have different level of capability. Some of them are very high functioning, have multiple physicians on at the same time. Some of them have surgeons and ORs available, sometimes immediately available. But the key intervention that the community ED can provide is airway, and diverting to a closer emergency department instead of going to trauma center for airway securement is almost always indicated if the patient actually needs an airway and you're not able to get it in the field for whatever reason. But our trauma centers really are the center of care for our trauma patients for many reasons. Obviously, they're experts. They see thousands of trauma patients a year. They have trauma-trained surgeons and emergency physicians side by side working together. They always have operating rooms available. They have almost every specialist known to mankind, from neurosurgeons, hand surgeons, ophthalmology, etc. But again, they may be much further away. So how do you make that decision? It's complex, and I think it needs to take in multiple factors. You know, what's going on with the patient? How far are you from each of the facilities? If you have the capability to call online medical direction if you're not sure. And of course, your protocols actually by state rule must cover this as well. Does anybody know which hospital is pictured here on the right? Scott, you can answer.
It appears to be CMC.
It is, in fact, CMC. Great. Does anybody know which hospital is pictured on the left? That is Babyland General Hospital in near Savannah, Georgia. So if you have Cabbage Patch Kids, that is where they're born. I would not recommend going there with a trauma patient. So what do trauma triage protocols typically look like? So most of them are based off the 2011 guidelines from the Centers for Disease Control. And this is a way to establish or recommend which patients are transferred to which type of hospitals. So it's based on physiologic criteria, mostly anatomic injury, and then mechanism of injury, and kind of cascades down. What are some issues that you all see with this plan, if any? Crickets. So some of the issues we've identified locally, one, just the fact that we have a 10-year-old guideline that has not been updated despite changes in trauma care and what we understand from EMS. I think it's interesting that we haven't updated these at all. The transport to a trauma center, it says you should go to the highest level of care within the defined trauma system. So there's some debate whether the higher level of care means that you always have to go to a level 1. Is a level 2 okay? And then in general, the cascading steps work really well, but once you start getting down to 3 and 4, it gets a little grayer in terms of the benefit to some of those patient groups, and we start getting into questions of under and over triage. And really, to me, I think this is a great starting point. A lot of EMS protocols are based on this, but make minor tweaks and adjustments based on what is going on in their region and what their local receiving centers want to do. You got to figure out how you're going to get there, whether you're going to a trauma center that's far away or a lower level trauma center maybe closer by. Obviously, for most folks, they show up in a ground ambulance. The benefits of the ground ambulance is it's already there. You got more room to work as compared to helicopter EMS. Minimal weight or patient restrictions, typically speaking. And then there's continuity of care. You don't have to hand over the care that you've already initiated on the scene to another group of providers like you would if you call for a helicopter. Of course, they do have to go on roads, so it would be traffic and road dependent. HEMS. So theoretically, it's very fast, right? 140 knots or so. So they should be able to move and go in a straight line. Around here, all the helicopters are RSI capable. We carry blood. And the quality improvement program for the helicopters get a lot of touch time with medical directors and a lot of people paying attention, which is really good. Cons, of course, weather dependent. Today we can fly, but yesterday we couldn't. And so that is very weather dependent for most of the helicopters in our region. There are weight restrictions. Sometimes you know the patient's weight and sometimes you don't. We also need to know the patient's girth, because a patient may fit weight-wise, but not be able to fit in the back of an EC-135. And then always, I don't talk too much about cost of HEMS transport because I'm not in the billing department, but there is a significant cost increase if you were to use a helicopter. So how do you decide which one are you going to pick? It's not just always about speed. There are different indicators that people have suggested in terms of helping you decide whether a helicopter may be warranted. Physiologic, anatomic, and based on mechanism of injury, similar to the trauma triage guidelines from the CDC. There are other considerations you always got to think about as well. Patients who have been exposed to hazardous materials typically should not be in an enclosed aircraft. What is your local resource availability? If you only have 1 or 2 ambulances in your county available, and one of them is going to be tied up for a 2-hour or 3 or 4-hour round trip to the trauma center, it may be wise to use a helicopter resource instead. And if you have multiple patients to be transported from the same scene, again, for a mass casualty, a helicopter can help get patients to a further away trauma center in the same amount of time. I've circled a couple of indications or potential indications for HEMS transport here. This is from the National Association of EMS Physicians, their guidelines for air medical dispatch. And to be honest with you, it's very broad. A lot of times people say, well, why did you fly that patient? They were discharged from the ER 6 hours later. Using retrospective patient outcomes to determine whether you should have called a helicopter is a fallacy in itself. Those patients typically aren't discharged from the ER unless they've had full body pan scans and been seen by trauma surgeons and ER docs, etc. Versus what you see on scene, you have to make a decision like, is HEMS appropriate? And the indications for HEMS, as you can see, some of them listed are pretty, I'm not going to say vague, but we see a lot of patients with, quote, significant abdominal pain. We see plenty of patients with just seatbelt signs. One of them was just ground provider perception of significant damage to the passenger compartment. So a lot of it's on your hands when you're on the scene. You've got to make the real-time decision, and you should always do that with pre-planning, whether it be via protocols, a similar list to this, and of course, always you need to know where your closest hospitals are from each scene. I want to take a second to talk about warning lights and sirens. This is something I'm very passionate about. In all the EMS agencies I work with, we see the trauma centers see a lot of traffic with lights and sirens coming in, and a lot of times we scratch our heads and try to figure out, what the crews were trying to accomplish. The time savings by use of warning lights and sirens in almost every single study is measured in minutes. Typically, depending on the study, anywhere from 2 to 6 minutes when you use warning light sirens. Again, that's very dependent on the roadway conditions, how far you're traveling, etc. But those minutes have never been shown to improve patient outcomes. There's no study out there. Every study that has been done on lights and sirens has shown conclusively that there is no difference in outcome whether you use lights and sirens or not. And that's in terms of patient-oriented outcomes. We do know that there are provider-oriented outcomes in that you're 2.7 times more likely to die in a motor vehicle collision if your ambulance is running lights and sirens. So it's a real impact to our providers. Of course, there's a patient in the back that could be injured or killed as well if you're involved in a motor vehicle collision. And we do know that bystanders are involved in more traffic collisions with ambulances running lights and sirens than not. Also, not that you necessarily need to consider this on every call, but as medical directors, we look at the increased legal risk to us every time an ambulance goes down the road with lights and sirens as well. And it does have an impact on stress level over time. Any comments or questions on warning lights and sirens? I know Dr. Swanson and his group at Medic and us at Novant, we have 100% QA for any run requiring the use of lights and sirens to make sure it was appropriate. All right, switching gears to interfacility transfers. A lot of times folks are confused about, well, why do they choose this level of service? Why do they choose to use a helicopter or not use a helicopter? Why do they use a ground ambulance? We don't see fixed wing that much, but the key concept is that the sending provider, almost around here, it's almost always an emergency physician. They have to choose the level of care provided, the mode of transportation, and how long to wait for that transportation. So that all comes back on the sending physician. And so it's sometimes a complex decision to make. You got to think about how long the patient's going to be outside the care of the physician while getting to the other hospital, the total time to definitive care, and the level of care needed, whether that be defined as ALS, BLS, critical care, etc. So one question I get asked a lot is, well, what defines critical care? I actually think I borrowed this slide from Dr. Swanson, but this is a great kind of graphic that talks about, you know, what can you do in the back of an ambulance? You got to be trained to do it, certified, state licensed to do it, and credentialed by a medical director. So in North Carolina, there is a cap. There is not a definition really of critical care except for whatever the medical director determines as critical care. But there is a cap on what paramedics can and can't do in the back of an ambulance. A lot of us define critical care by putting a nurse in the unit, but that's not necessarily required. This is a slide I give to our community ED docs about when they need to transfer a patient to the tertiary care center, how to think about which button for us, it's a button to click when you request transfer in terms of getting the right resource to you as efficiently as possible. And really, it's a two-step decision. The first step is, do you need critical care? Because if you do need critical care, then that kind of sends you down a different pathway to using one of our critical care ambulances or our helicopter. We do have ALS ambulances, and the 911 system also supports us, but the 911 system does not provide true critical care for interfacility transfers. In fact, typically they'll need to borrow a nurse for some of our sicker patients. So do we need critical care? For trauma patients, it just depends. And again, the question of what is critical care for that patient comes down to the sending physician, hopefully with knowledge of how their local system works. But vasoactive drips, ventilator settings, that sort of thing typically fall in the critical care arena. And then you also have to answer, is it time dependent? So we say that, you know, trauma is a time-dependent disease, a lot of these patients have already been evaluated by the emergency physician at the community hospital, and they're in a really good position to know if it's a time-dependent lesion. A lot of these patients have already been scanned, and so even though the patient may be sick and benefit from a trauma care at a trauma center, whether the ER physician needs to kind of decide, is this a time-dependent lesion such that the patient's likely to go to the operating room? We probably need to move very quickly, versus they need to be admitted to the trauma center, but they aren't going to be operated on tonight. Probably not as time-dependent. Questions? I want to take a second to talk about a lot of the delays that we see. So especially with the helicopter program, we train a lot on how to get patients moved quickly out of the hospital setting into the helicopter so that we can utilize the speed of the helicopter to the patient's advantage. Unfortunately, we see a significant percentage of our requests are delayed due to a few simple things that can be fixed. And honestly, the number one delay in transfer of patients in our system is paperwork. So for those of you who don't do interfacility transfers day in and day out, please note that there are a lot of paperwork requirements that the hospital systems have. Each hospital system has a different requirement for what paperwork is needed. And the helicopter EMS agency also has different requirements for what kind of paperwork they need. But waiting until the unit arrives at the sending facility to start the paperwork is probably not an ideal way to initiate a time-sensitive transfer. So their paperwork for medical necessity, EMTALA paperwork, and you're always supposed to send the complete patient care record with imaging as well anytime you transfer a patient. Getting that stuff done in advance can save considerable time. Interventions, so our bedside time in terms of patient care comes down to a few things. We need to do an initial assessment, an initial set of vital signs, and then transfer them over to our monitor, which is we can do pretty quickly because we train on it. But medications a lot of times slow us down a lot. And it's not that the patient doesn't need necessarily those medications, but the question is, do they need them in drip form? And if so, how important are those drips? Because every single time we have to transfer a drip from a hospital pump to our interfacility pumps, that takes time. It takes time to physically do it, and it takes time to double check it. And so when you have a patient on 2 or 3 drips, because you want them sedated in a certain way, and maybe they're on something for seizure prophylaxis, if you want that drip to continue, then we have to do the same kind of transfer over for each drip each time. So one way we get around that is asking politely to change from drips to push dose medications. So instead of the propofol and fentanyl drips, if we could just switch to fentanyl and Versed pushes instead, if that's okay with the sending provider, that can actually save us 5 or 6 minutes just by doing that. Specialty medications come up a lot. We see a lot of patients on blood thinners, and the sending physician wants to reverse those blood thinners, probably because they are critically bleeding somewhere, including the head. However, waiting until the aircraft shows up to order the PCC from pharmacy is probably not a good use of everyone's time. And so you really got to make a decision on how important that PCC is versus how quickly can we get the patient to the trauma center. For most places don't carry PCC in their ER PICSs. The other thing is ventilator settings. We will put the patient on a ventilator. We do not like to bag patients in the back of the aircraft. So it does take us a little time to transfer vent settings over. Having respiratory at the bedside is super helpful to help us do that in a safe manner. The last thing we see is bed placement delays. So in our system, and really any interfacility transfer, the accepting facility has to say yes, and they have to have a place for the patient. That process does take a little bit of time. We have changed our way we order these placements so that if you've requested a bed, you don't have to wait for the bed to get the aircraft moving. but that means that you are now committed to transferring the patient and accepting the patient. And the way we've accomplished that is just that our trauma center will always say yes if the aircraft is already there, to the point that if we have no beds, then we'll automatically accept them into our emergency department, so that we don't ever delay care waiting on the dotting the I's and crossing the T's for do we have placement or not. A couple slides about patient care in the back of the aircraft or ambulance, going from a community hospital to the trauma center. Hopefully, all the life-saving interventions have already been done. So even the community ED docs should be able to secure airway, should be able to place a chest tube if the patient needed one, and certainly have blood products and anticoagulation reversal agents, and should have already given those, hopefully. That's not always true, and so we tell our aircraft crews and our CCT crews that if the ER doc has not already done that, but they need it, then we need to be able to support any of these processes in the back of the unit if necessary. We don't like to do any of these in the back of a moving helicopter or ambulance, especially tubing people or putting chest tubes in, but we are capable to do that if we have to. We do carry, obviously, blood products. We've gone back and forth about carrying PCC, and that's still under active exploration. So once the ABCs are done, the patient may have been shuttled out of the ER very, very quickly because the ER doc wants to get them to the trauma center appropriately. So there's several things we can do in terms of harm reduction to make sure that the patient's morbidity is improved. So temperature management is incredibly important, more so we see in the aircraft than ambulances, but almost universally the back of the transport unit itself is cooler than what we want the patient to be. And a lot of patients arrive to the trauma center after transfer being relatively hypothermic. Turning the heat up in the back of the ambulance or aircraft, keeping the patient well covered, very, very important in terms of coagulopathy. We carry antibiotics. If the sending team has not started antibiotics for an open fracture, then we need to be able to initiate that within a certain amount of time to improve patient outcomes. Balancing the fluid resuscitation. Again, if the patient becomes hypotensive in the back of the unit, being able to not only give IV fluids, but blood products as well. And please, 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 if it's not already been done or it's not done adequately, please, now is a good time between point A and point B to help manage that patient's pain. So here I'd like to get some discussion on this slide if possible. This comes up a lot of time for us on our ground critical care trucks, and the question is, who decides if the ambulance should use for us red lights and sirens? Dr. Swanson, can you comment on this? How you do it at Atrium?
Sure. The sending physician is responsible for the patient getting to the referring facility, so they're responsible for technically the crew as well as the mode, whether that's air or ground. So we do defer to them on that. When it comes to lights and siren, as you mentioned previously, the actual time savings is so negligible that we defer that to our protocols. I'm not going to run lights and sirens. Someone who does not have an emergent time-sensitive process, that just puts people at risk, just as you mentioned earlier.
Great. Yeah. So so you have that protocolized?
Yes.
Got it. Yeah, protocol is an excellent way to handle this. So as Dr. Swanson was saying, that the sending physician is responsible for a lot of the decisions that come into play in terms of whether you use an aircraft or a ground ambulance, whether you call CCT or you use a 911 asset. A lot of decisions are totally, almost totally in the sending physician's domain. But as Dr. Swanson kind of stated, we, the transport team and the medical directors, are experts in knowing when lights and sirens are needed or not needed, and that's a decision that should be made at the ambulance or at the ambulance level, whether that be by protocol or by crew discretion, closely supervised. It is not within the sending physician's kind of order panel to be able to tell us how to drive our ambulances, right? That's on us one way or another. I like the approach of protocolizing some things, then also having the transport teams who's there constantly reassessing the patient, giving them the flexibility to make decisions as well, whether it be upgrade or downgrade. And really, it's their risk more than anyone else. And so I want them to feel empowered to slow down and not use red lights and sirens, despite how the sending physician feels, and despite honestly how sick the patients are. As I tell our crews time and time again, the patient may be very, very, very ill, but if arriving at the trauma center is 1 minute earlier, how likely is that 1 minute going to play into the morbidity or mortality of that patient? And I think our crews have been doing this long enough to realize that it's relatively rare that minute actually matters in an inter-facility transfer. So certainly I'm the one who takes the calls. My crews carry my cell phone number, and if they ever get into an argument about this, just tell them that it was my orders and give them my card, and I'm happy to take that phone call. Thankfully, that phone doesn't ring very often. I do get some complaints occasionally, kind of after the fact, but almost universally, the complaints are they feel it took us too long to get there in the first place. It's not that it took us too long to drive from Huntersville to Presbyterian Hospital, right? It's not a common complaint that we see. And like I said earlier, we QA anything that goes lights and sirens. All right, let's talk about reports. So one of the things that we've noticed at the MTAC rack level is that we see a lot of crews come into the trauma center, and the trauma team was not expecting them. Not that we didn't know that the patient was coming, but we didn't know exactly when the patient was coming. And they said, well, we didn't want to call report. Why bother? Report's already been called. And so I want to disabuse anybody of the notion that that the call-in report from the ambulance is not important. It's incredibly important for many, many reasons. One is there's no way that our outside hospitals are going to be able to give us a realistic ETA. They don't know how long it's going to take for y'all to get there. They don't know how traffic is. They just can't really provide us a realistic time frame, and when they try, it's almost never right, positive or negative. That phone call or radio report, it used to be, gives time for the trauma team to prepare and lets us use our resources wisely, so that we're not sitting waiting for 24 minutes for a sick trauma to come in when we could have been taking care of other patients, but also that we have more than 1 minute when we see the ambulance pull up in the bay to gather the team to discuss roles and come up with a pre-plan and get all our PPE on. Additionally, you all who are transporting the patient, you have a real-time picture of how the patient has done since they left the sending facility. And we want to know that because we got a report that said the patient was not sick, and you're looking at a patient like, this patient is very sick. We may need to upgrade that response to a higher level of response in terms of including respiratory therapy, getting the trauma surgeon quicker to the bedside, or adding more team members at the bedside as well. This includes specialists. If we know the patient has an open fracture that's confirmed, we may not have gotten that on the report, or we may have missed it, but you call us and say, hey, we've got an open fracture, we can call the orthopedist to the bedside to further reduce that, that morbidity. It should be very, very brief. Again, all we need to know is how sick is the patient, how long is it going to be there, you know, what do you need, plus or minus any orders. So I think you realistically could do that in less than 30 seconds. The other important piece that we see for bedside handoff is a lack of consistency between crews and between agencies on the initial report. So for MTAC, we're trying to push out the MIST report, so really mechanism injury, injuries, signs and symptoms and treatments, with a goal of a less than 60-second handoff that covers what we need to know, and we want that for interfacility transfers as well, especially if there's been a change, but even if there's not a change, to make sure that everybody in the trauma bay is clear about where the patient is right now, so they can develop an efficient plan to get the patient the care they need. That does not alleviate, in my opinion, a more detailed report that we will need later. The nurses always have certain things that they need to document, and the physician team members may also need additional information, and we like to hear the detailed report. We just want to hear an initial report so that we can immediately start our ABC assessment, initial stabilization, coming up with a plan. And then if you don't mind, please don't leave, don't run out of the bay after the 60-second report. Stay around so that we can either get a more detailed report from you or ask you very specific clinical questions to help us decide what's best for the patient. Nothing drives me crazier than getting a really good trauma report in the MIST format. It's 45 seconds and we're going, and then 3 minutes later it's like, oh my gosh, I really wanted to know, was the patient on anticoagulants, or what treatment did they get at outside hospital? And I look around and the EMS team has already cleaned their stretcher and left the building. I know that you all are very, very busy, and some of you have actual requirements and are monitored in terms of how long you can stay at the hospital, but sticking around for 5 to 6 minutes on a critical trauma transfer patient can be super helpful to those of us trying to take care of that patient. Again, there's lots of pieces of information that we'll never get if we don't hear it from you. Scott, would you say that's accurate?
Yes, that's a great assessment of it. Thank you.
And lastly, I wanted to talk about quality improvement. A lot of you may not be involved in quality improvement projects for your agency, but quality improvement, quality assurance, PI, however you want to call it, incredibly important to trauma patients. We all have areas where we can improve, whether it be pre-hospital care, interfacility care, community ED care, and trauma center care. This is a constant learning process for all of us. Like I said, I've been doing this for 20 years. Dr. Swanson's been doing this for forever. But we all know that we can improve and can improve the care that we provide at a system level, and that means to the individual patient level as well, if we get all of the key players to participate in quality improvement. And certainly the RAC system is designed around this theory as well. Some of the things, some of the metrics that are commonly tracked: scene time, airway interventions, under and over triage, specifically for HEMS, but I would argue for any use of warning lights and sirens. And now we're starting to pay more and more attention to the data collection piece of that, not just scene times, but are we getting all the data elements we need in our PCRs so that the RAC coordinators have the information, apples to apples comparison between agencies, to really start to dive into any issues in terms of ability to improve trauma care to our patients. In my opinion, feedback to crews is one of the most important but difficult to accomplish parts of a quality improvement system. I think everybody who's involved in a care of a very critically injured patient, whether it be adult, child, infant, and regardless of where they are on the care spectrum, they need some level of feedback about those patients, because without the feedback at the ground or air provider level, without even first responders getting any feedback at all, I feel like they don't feel like they're connected and part of a system. And even if they did a fantastic job, they want to hear that that patient, you know, went to the operating room and had a prolonged course, but is doing great. Right? Everybody likes to hear some of the good stories. I think sometimes you need to hear the bad stories as well. But if we never close the loop with our providers and give them very specific patient feedback, I think they lose that important piece of A, human touch, and B, the ability to QA in their own mind what they could have done better, or just as importantly, pat themselves on the back. All right, key takeaways. We're running a little bit ahead of schedule. I apologize for that, but we'll hopefully we'll have some time for some questions. My important points that I wanted to convey during this lecture is that A, pre-hospital trauma care is incredibly important. The 911 providers that go out there and answer the motor vehicle collision and gunshot wound and stabbings and all the other falls and all the other trauma care that we see, the interventions when required that they can do are incredibly life-saving, and we don't get to do those every single day. It's, you know, we don't put tourniquets every single day, that sort of thing, but having the ability to do that and doing it in a timely manner really can make an impact on patient survival. Areas for time efficiencies, in my opinion, scene time, being careful, watch the clock on scene time, just be as efficient as you can while you're on scene, only do the absolute minimum necessary that has to be done on scene, and then carry on the care in the back of the ambulance or helicopter. And transport time, I think in some instances a helicopter is faster, in some instances a helicopter is slower. You need to know the areas of your jurisdiction where a helicopter may be of benefit to you. And similarly, the use of lights and sirens is probably not going to benefit most patients most of the time. So making sure that you don't try to make up for prolonged scene time by driving faster is probably not the best answer. And then destination choice, is it worth an hour-and-a-half drive to the trauma center versus a 10-minute drive to your local hospital? That's got to be made, the decision needs to be made in advance of when you're going to go to a trauma center and when you're not going to go to a trauma center, and that's based on your community hospital, what they're capable of, and what your EMS leaders, including the medical director, think is best for patients in your area. If you are going to use HEMS in the pre-hospital setting, that should be pre-planned, whether it's by protocol, ideally. And I've seen different agencies do different things. Some folks have a map with a line in it saying, hey, if you're on this side of the line, a helicopter may save you time, and when you're not on that side of the line, it probably won't. But whatever it is, make it easy for your EMS providers, as easy as possible, to be able to make that decision and then support their decisions one way or the other. The sending physician is on the hook for a lot of things. They have to choose the people who are going to be on caring for the patient between point A and point B. So they need to A, understand the difference between BLS, ALS, and critical care, and B, know when to ask for each. They have to choose the vehicle, so they need to be facile enough to know when a helicopter may or may not be indicated. And that does include the equipment that goes in the back. So if the patient requires a ventilator, they're in charge of making sure the transport vehicle that shows up has a ventilator on it. Interfacility transfers require careful coordination and communication. So the coordination piece, for the most part, is on the sending facility team, making the right phone calls, clicking the right buttons. And the communication piece, while the sending hospital always talks to the trauma center, we want the interfacility crews to close the final loop on that communication, call in a radio report or a phone report when you're 10 minutes out. Give us an update so we can get the right care team to the bedside and be ready for you. That brief report is important on the phone call, the missed report at the bedside, and then please, if at all possible, please stay for the initial resuscitation so that we can ask you more questions that may not have been answered by the missed report. And with that, I'll open it to questions.
Dr. Loyd, Dr. Swanson would like for you to define forever.
That's a good question. I actually, how long have you been doing this, Dr. Swanson?
Coming up on 29 years.
I would say anything over 28 years is forever. I'll say that until I get another 10 years under my belt, I guess.
Perfect.
There is a question about, do the EMS crews know what pertinent information is needed upon arrival to the trauma room?
Good question. Yeah, so that's a great question. We've, I think, Scott, correct me if I'm wrong, the last we talked, we were going to start, we're going to develop some sort of memory aid to put in the trauma bay to help our responders kind of know what we want to hear. Of course, training in advance is always better than having to use a chart on the wall, but this missed, if you can see it, the missed report, you know, there's some things we absolutely have to know, you know, if possible, the identifying the patient's important if you know identifying information. But really, its mechanism of injury, you know, quickly tells we don't need to know that it was a 1998 Ford Taurus with 2 doors and it's green, right? But it was a, you know, it was a compact car, hit a tree with significant damage, and patient was ejected. Great. You know, what have we identified injuries? Again, for interfacility transports, right? We're not looking for the broken toe. It's, you know, the sending physician has identified a head bleed and a pneumothorax. The vital signs, highest, you know, heart rate, lowest blood pressure, initial GCS, any changes en route, and then what treatments broadly. You know, we don't necessarily need to know that it was 50 micrograms of fentanyl IV push at 12-22 hours. The patient has received fentanyl and Versed for sedation. Boom. Again, 45 seconds to a minute of what are the brass tacks things that they need to know. And that will change by patient, so it's never going to be 100%. But if you kind of always go in this order, I think it'll help.
Yes, and to add on to that, also, we're Dr. Loyd was correct. We're trying to roll out some to make the bedside report more standardized by using an example like the MIST. Trying to collect a little bit more data to see if we can actually make a true impact, and by using that format, and then offer some optional education for EMS systems to use if they choose to. Ultimately, though, I believe it's going to fall to the medical directors to choose if they want to endorse this or not, but we're going to suggest it.
Yeah, I think it's a great plan to attempt a standardized approach to this. It will probably take all those things that you mentioned, the initial education, memory aids, and QA on the back end as well. This is the number 2 complaint I get for CCT. Is that the receiving trauma center didn't like the report that they got. The number 1 being it takes us too long to get there. They always say that.
Another comment made was to also include things such as meds. The last time that a medication was given, to know if they need to be redosed, I assume for things such as paralytics.
Yeah, you absolutely are going to need to get that information across. I'm not. I would hesitate to give times or doses in the initial MIST format, unless you think it's directly related to what the patient is experiencing now in the next couple of minutes. And what I would typically, they got ROC or they got Beck or something, or they whatever else. And then in a couple minutes, I'll probably ask you what time and dosing and that sort of thing. And I know the nurses are going to want to know that and document that in our records for sure. But too much information sharing during that initial, again, 60 seconds. What we're trying to do in that initial, as soon as the patient gets there, is give the transporting providers the time to give us the critical information that we need to be able to do ABC. And that is not to say that the other information in the report is not valuable. It's just we're giving you dedicated time to talk, and then we need to do a couple of things really quickly to make sure that A, B, and C are covered. And then we have time to step back and get more details.
Excellent. I see a hand raised also. Elijah, do you have a question you want to ask?
I do. First off, thank you, Dr. Loyd, for doing this. I really appreciate it. I work for a medic, and I can't remember the last time someone requested a helicopter within Mecklenburg County. Do you have like a story of a call to where the helicopter was like correctly indicated and actually transported someone from within Mecklenburg County to a trauma center?
I will defer to Dr. Swanson. During my fellowship year, I don't think that occurred at all. I can certainly think of some areas in the county where if there was a pin-in, that a helicopter, may be indicated. But I'll defer to, if there's an actual patient example, I'll defer to Dr. Swanson.
I don't know that I have a specific patient example, but we do this about 6 times a year. So as you know, Elijah, it's a very rare event. And it's typically somebody who's in one of the far reaches of the county. So maybe way up north, Cornelius, Davidson, Huntersville area, way down in the southeast beyond Steel Creek. And at a time when it's 4 o'clock in the afternoon, 4:30 in the afternoon, and you may have instead of a 20-minute drive in, a 45-minute drive in to Uptown. And as Dr. Loyd just mentioned, it could be one of those instances where somebody is entrapped. The entrapment extrication is going to take 20 minutes or so, and you would have time to get a helicopter on scene at that point in time. But again, it's a rare event within the county, just because of our typical drive times are not that great. And when you consider the helicopter has to be dispatched, has to respond, has to get to the scene, you lose a lot of that time when you're already relatively close to the trauma centers.
Yeah, a lot of people, helicopters are incredibly fast. Once they're in the air, getting that helicopter in the air is at least a 10-minute adventure. And then we have to get there, and then we have to land and land safely. And landing on a scene is the most dangerous thing that we do. And so landing on the scene takes more than 60 seconds, right? We fly a complete 360-degree loop, and the actual descent time, and then we have to power down a little bit, at least to get the crew out. So it is not necessarily a rapid endeavor to get to you. And so if you're not entrapped, for the most part in an urban area like Mecklenburg County, the time factor is probably not going to work out in your favor. That's a different math than transferring patients hospital to hospital for us. So for example, for Met Hill, we use the helicopter probably about once a month for trauma transfers, but that's a pre-designated landing zone. We can, in our healthcare system, we can request a helicopter before we even talk to the trauma surgeon. And for patients who are medically complex, in addition to, they've been shot and we had to intubate them. So now we require a ventilator and a couple of drips. We would prefer to have a critical care nurse and a critical care paramedic take care of those patients. And with our current CCT ground staffing, there's a really good chance at night that the helicopter will be able to make that much more efficiently than our critical care ground truck can, especially in the wee hours in the morning. So That's a good question.
And if I can add, then it's also different, being in Mecklenburg County versus one of the, counties that are, one or two counties away from your trauma centers. And when you're looking at, as Dr. Loyd mentioned before, a 15, 20-minute drive versus a 60-minute drive, then you do rapidly gain a lot of benefit from utilizing helicopter EMS.
Yeah, I know we routinely review calls at MTAC where it was 70 to 80 minutes from some of the outer reaches of our region drive time, and that's a long time to be on the ground. That being said, if the same call happened yesterday during the weather, I mean, you're going to have to do it by ground, right? So even though you'd love to have a helicopter, it's not always an option. So you've got to be prepared for long transport times.
Thank you both.
Well, thank you. Anyone else? Scott, any good questions?
I had a quick one. You mentioned starting a transfer prior to a bed being secured. Have you run into any problems with that, especially in the current environment where beds may not be as plentiful as our hospitals are fuller? And can you also speak a little bit on the difference between ED to ED transfers versus inpatient transfers?
Yeah, good question. So it's different if you within a health system. So that in our healthcare system at Novant, emergency care and trauma care are under the same leadership structure. And so we have all come together and agreed that the trauma answer is always, yes, we will accept. And the bed answer is always, we will just take you to the ED. And we always have an ED bed dedicated towards trauma. So that's kind of how we've answered that question. But the reality, in my opinion, this is totally Josh's opinion. When somebody gets shot on the side of the road, the trauma centers don't go on trauma diversion. That's not a real thing, right? And so, in my opinion, the same thing applies to the patient who got shot and walked into our Mint Hill emergency department, for example. Right? If that patient had been shot across the street from Presbyterian, we wouldn't say no. And so just because they got shot in a different part of the county and their friend drove them to one of our outlying hospitals, the patient still needs to come to our trauma center. And so the answer should be yes. And that's a kind of philosophy that we've driven. And thankfully, we've actually been able to then push that philosophy to stroke as well. And so now our stroke uses our auto launch stuff as well, so that even if there's no stroke beds available in the hospital, we will clear an ED bed and we'll take all LVOs to Presbyterian, regardless of status, because the answer is always going to be yes. And magically, those beds tend to appear once really sick LVOs or trauma patients show up. It's one of those things that the hospitals. Are we recording this? The hospitals, can be at 102% capacity, but when really sick patients who really need care show up, we find beds for them. That's a good question. The other question is ED transfers versus inpatient transfers. There's two. Can you clarify that question a little bit for me, Scott?
Just curious if there's any nuances or differences between the two. Any challenges you've experienced, I guess.
So there's two pieces. One, if it's leaving an ED going somewhere else, then that EMTALA applies. The opposite is not true. So if it's an inpatient transfer for whatever reason, this is not very trauma specific, but inpatient transfer to inpatient, EMTALA doesn't apply. So there are kind of different regulatory rules on that. But what we have seen is that patients can wait in the ED trying to get they've been approved for an inpatient bed at Presbyterian, but there are no beds available. And then it's the question, well, how long do you sit at Huntersville Emergency Department waiting for a bed before you just the patient needs to go and you send them ED to ED instead of waiting on that bed. That's a complex decision. And in our system, we depend on the ED doc to be conscious, the sending ED doc to be conscious of how many dominoes fall if you send that patient to the Presbyterian ED, which is also very busy. And somebody's got to have to take care of that patient. And so, as long as the trauma surgeon says, yes, I'll see the patient in the ED, we will give them an ED bed, but we try not to do that as much as possible unless it's a really critically ill person that needs to go for operative intervention, just because taking your ED boarding problem and giving it to another ED doesn't necessarily help anyone unless that patient really needs a very specific resource that you can't provide. So we're still wrestling with the right answer to that question. But we have determined that if the trauma surgeon says that patient has to be downtown right now, then we will auto accept them to the emergency department without question.
Great, thank you.
Scott and Josh, if I can sort of add in one
Yes.
thing, CMS, Center for Medicaid Services, they have no problem with outpatient to outpatient transfers. They have no problem with inpatient to inpatient transfers. What they do distinctly frown upon is an inpatient to an outpatient transfer, meaning the inpatient who is on a floor bed being transferred to an emergency department. That transfer needs to be inpatient to inpatient. Now, it may so happen to be on a rare occasion that patient ends up having to sit in the ED until his bed is ready. But what you can't do is accept the patient from an inpatient floor to an outpatient emergency department.
That's a great clarification. Thank you. I see another hand raised. Dawn, you have a question or comment?
So I think you answered it, but hi, I have a question. First of all, for Dr. Swanson, the information that you just gave regarding accepting of transfers, is it okay to accept a patient from an outlying facility that is in an inpatient floor, but they need, say it's a trauma patient that is probably going to need ICU? Is it okay to accept that patient to the emergency department? I guess my question is emergency department higher level of care than a regular floor when we know that patient's going to go to the ICU? When they get,
it's not that it's viewed as a higher level or a lower level of care. It's all in the fact of being inpatient versus being outpatient. And so the inpatient needs to be accepted to an inpatient location and by an inpatient service. Now that's not to mean that the patient will never end up in the emergency department. On rare occasions they will. But what you don't do is accept the inpatient and accept them to the outpatient facility.
Okay. All right. I think I understand what but my other question was for Dr. Loyd regarding patients that are being transferred to a trauma center that need, like, I see this occasionally, as long as it doesn't delay care. Like, say the patient needs a chest tube, for our doctors to, if they, to suggest placing a chest tube prior to transfer, or how does that get, not that it doesn't happen that often, but I'm just curious as far as, is that pretty much the rule as long as it doesn't delay anything as far as like doing anything additional? Like, if our doctor looks at the CT and says, oh, this guy needs a chest tube, or this, they need blood or something, it's okay to call back and have a conversation?
Yeah, that's a good question. So the expert on the other end of the phone can make any suggestion in terms of patient care that they want, but they can't tell the ER doctor what they have to do for the patient, and they can't make an acceptance conditional based on that. So they can highly suggest, and they can say on a recorded line, I think this patient needs a chest tube. This may be a life-threatening condition, but they can't say you must put a chest tube in prior to transfer. That's not technically allowed by MTAC.
Gotcha. Thank you.
You're welcome. Yeah, we see that all the time. Some ER docs, put the chest tube in. Some of them don't. Those get heavily reviewed, right? And so that's a internal kind of QA sort of thing, retrospectively. Generally speaking, if you're calling an expert, you should probably take that expert's advice for the most part. But that's in terms of like the EMTALA and the accepting the patient and getting them out of there. That's just like our doc at Presbyterian can say, oh, that sounds really, really bad. You should fly the patient. That's a suggestion, and the sending physician has the final card on all those things. Good question. All right, if you need some light reading, Dr. Swanson wrote a great article about aeromedical transport. Scott, that's all I got.
That's yours. I just edited.
I see some familiar names on there. This is awesome talk. There's a lot of great points and some good questions. I think if anything, this brings up the need for more discussion on this and more education, as mentioned a few times. I just wanted to point out that I looked it up while you were talking. Babyland General Hospital is a real place.
It is,
and
yeah,
and you can't go visit.
I've been. That's how I knew.
But thank you so much. This was an incredible talk. Thank you to everybody for their participation. And if you have any additional questions that you'd like to be passed on to Dr. Loyd, send them my way, and I will forward them on to him. Thank you, everybody.
Thank you, Scott. And Dr. Swanson.